Good afternoon, everyone. Welcome to this webinar entitled Penile Duplex Doppler Ultrasonography, presented by Dr. Jeffrey Sklar. The AIUM is accredited by the ACCME. This webinar is designated for 1 AMA PRA Category 1 credit. By the conclusion of this webinar, participants should be able to describe the functional anatomy of the penis, know the basics of the technique of color duplex Doppler ultrasound of the penis, know the normal parameters of color duplex Doppler ultrasound of the penis, and know the indications for color duplex Doppler ultrasound of the penis. As an ACCME accredited provider, it is the AIUM's policy to ensure that the contents and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Jeffrey Sklar and Darcy Bolito de Luna have no disclosures. At the conclusion of the webinar, you will be able to access the CME test and evaluation located on the AIUM website. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. For more information on accessing the CME test and claiming credit, please refer to the handout provided in the dashboard on the right side of your screen. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During today's presentation, if you have questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time he will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now we're pleased to present Dr. Jeffrey Sklar.
Thank you, Darcy. Hopefully everybody can see my screen. Welcome to the webinar. Today I'm going to be discussing penile duplex Doppler ultrasound. If you look at my credentials, it's a little odd. I mainly am a cancer surgeon. However, to break up the severity of the cancer patients, I also got into erectile function and male sexual health, and that's where I got my interest in doing penile Doppler ultrasound. So I don't have anything to disclose, and I'm really not receiving any financial support for this webinar. And these are my objectives, essentially to orient you to functional penile anatomy. You need to know a little bit about the anatomy to understand both the indications and how to interpret the duplex ultrasound. And then we're going to discuss these indications for the duplex ultrasound and review a protocol for penile duplex Doppler ultrasound. And then to go over the normal parameters for penile duplex ultrasound and show you some cases that we'll have you participate in through poll responses to see if you have a good understanding of what we're going through. Just a little bit of basic anatomy of the penis. So the penis is sort of a unique vascular structure. It has two erectile chambers in the middle called the corpus cavernosum. These are what hold the blood for erections. And above them are the dorsal vein and the dorsal arteries of the penis. So these are things you will be seeing on duplex ultrasound. And in the middle of the corporal bodies are the cavernosal arteries. You also will be seeing them. The tunica albuginea is the coating of the erectile chamber and is associated with some scarring abnormalities in Peyronie's disease. And ventrally is the urethra, the urine tube. So first, we're going to talk just a little bit about the tunica albuginea, or the coating of the erectile chamber. It is the covering of the corpora cavernosa, and it's bilayered structured with multiple sublayers. Their interlayer bundles support and contain the cavernosal tissue, and they're oriented circularly. So you can see that here. Radiating from this inner layer are intercavernosal pillars, these struts on the right-hand side of the screen, that augment the septum and provide support to the erectile tissues. So it gives the penis stability and resist buckling forces. The outer layer are oriented longitudinally, and you can see them on the top here, that outer layer, and they extend from the glans penis to the proximal crura. And the crura is where the erectile chambers split and insert on the pubic bone. And this is where you get stability. Otherwise, the penis would wobble around. they they insert to the pubic rami, but there's some absence between the 5 and 7 o'clock positions down underneath on the bottom, and that's where the penis sort of is at risk for buckling injuries that can be associated with abnormalities like Peyronie's disease. The strength and thickness of the tunica correlate in a statistically significant fashion with the location. The most vulnerable area, as I said, is located the ventral groove between the 5 and 7 o'clock positions, right in here, where there's really only one layer of that coating the erectile chamber. Now, if you look, these are the functions of each of the areas. The cavernosa supports the spongiosum and the glans, and that's what carries the blood and causes the erection. The tunica albuginea contains and protects the erectile tissue and provides rigidity of the corpora cavernosa. It also participates in the veno-occlusive mechanism. So because it's the coating, it has small veins that course through it. As the penis stretches and fills with blood, those veins are stretched, and that causes veno-occlusion. So as you stretch the penis, blood gets trapped into the penis. So any disorder that inhibits the penis's innate ability to stretch may also impair erectile function. Smooth muscle is what regulates the blood flow into and out of the sinusoids, and it also lines the cavernosal arteries as well as the dorsal arteries. The ischiocavernosus muscle actually squeezes and pumps the blood distally to hasten the erection and provide penile rigidity during the rigid erection phase. And we'll talk about these specific phases of erection because these are very important to anybody who's going to be doing a penile Doppler and understanding the timing of these. The bulbar cavernosus muscles compress the bulb and help expel semen with orgasm. The corpus spongiosum pressurizes and constricts the urethral lumen to allow forceful expulsion of semen and to some degree urine. The glans, penis acts as a cushion to lessen the impact of the penis on the female organs, provides sensory input to facilitate erection and enhance pleasure, and facilitates intromission because of its cone shape. Now, I will tell you, most men, when they hear this, they never thought that the penis had so much stuff in there and really don't appreciate the functional significance of most of it. The source of the penile blood supply is usually the internal pudendal artery, as you can see here. It comes in and it's a terminal branch of the internal iliac artery. So things that may impact blood flow that you never really think about are patients with previous surgery, the internal iliac artery, or even the external iliac artery, and the most common of these being renal transplantation, because the kidneys that are hooked up for renal transplantation are hooked to these vessels. So you can sometimes get what's called a steal phenomenon, because now that blood supply is going to a transplanted kidney and it's not really going to the penis. In many instances, you see some accessory arteries. These may arise from the external iliac, obturator, or vesicle branches, and they may provide even dominant blood. The cavernosal artery, if you go ventrally, you can see the bulbourethral artery, and many of you will see circumflex arteries in both the transverse and longitudinal planes. And you do need to know a little bit about penile physiology as to, because it does correlate to what you're going to see with patients as you do these studies. So in the normal situation, now I'm going to emphasize that while you're doing a penile Doppler ultrasound, that is not a normal situation. That involves a chemically stimulated erection. So what I'm talking about right now, is the natural situation where sexual stimulation triggers the release of neurotransmitters from the cavernosal nerve terminals. So this is either with sexual arousal, visual, or auditory, or even sensory smell sensation can trigger these as well. This results in relaxation of the smooth muscles and dilation of the arterioles and arteries by increased blood flow with both diastolic and systolic phases. So it seems counterintuitive that the actual stimulation does not cause muscle contraction, it causes muscle relaxation. So the arteries to the penis, the smooth muscle in them relaxes, the diameter of the artery increases, blood goes faster through the arteries and then goes into the what's called sinusoidal spaces, these cavities within the corpora cavernosa. They fill up with blood, and then the penis will stretch in length and width and compress the subtunical venous plexuses. So you see these veins right here running under that tunica albuginea layer. As these sinusoids stretch, these veins are effectively compressed and blood is trapped into the penis. So when this happens, the veins are occluded and the venous outflow becomes a minimum. And you will see an increase in the arterial pressure, both the oxygen delivery as well as the intracavernosal pressure will increase to around 100 millimeters of mercury, which is pretty darn good. It raises the penis from the dependent position to the erect state and to the full erection phase. There's a further pressure increase to several hundred millimeters of mercury with contraction of the ischiocavernosus muscles, and that gives you the rigid erection phase. So the penis can be full and it can be rigid. So that interplay of the ischio-cavernous muscle gives us the rigid erection phase. Now, many of you, this is not commonly seen during the penile duplex Doppler ultrasound because that requires significant, usually stimulation to get that kind of stimulation. Now, as far as the physiology is concerned, there's great more detail as far as the neurotransmitters, but just in brief, it works through what's called a nitric oxide pathway to cause smooth muscle relaxation. So many of you have heard about the drugs Viagra, Cialis, and Stendra. These drugs all work through this nitric oxide pathway. And again, you have to have sensory input, so you have to have intact nervous system to get the smooth muscle relaxation. So your spinal cord patients will not function quite normally, and so when you do their Dopplers, you may see some different outcomes based on the fact that their physiology is somewhat different. Now, I'm just trying to get you to understand exactly how the system does work. And this is looking at an arteriolar smooth muscle. And in the contracted, this is sort of how it is when men are just sort of walking around at all times. Our arterial inflow to the penis is contracted. As you have stimulation, you get relaxation. It fills these sinusoids, and these veins that are always open are now closed during erection. Now, a man would not want that to be the case just during the normal day because then the penis would always be erect. So this is the resting state, and this is the state with sexual stimulation. Now, one of the other things, and this is a very difficult diagram to kind of comprehend, but it's really important to those people who are going to be doing penile duplex Doppler ultrasounds, is you need to understand that there are changes in the blood flow and the pressures in the penis as we do the study. With the flaccid penis, you're looking at right here. Whoops, hang on, I'm going to go back one. You have very little inflow and very low corporal pressures. Once the penis is injected, you get into this what's called latence phase right here, and you see an increase in arterial pressure, and still you don't have much in the way of intracorporeal pressure because it takes a significant increase to build up, and then you have to get some fullness or tumescence, and that's this phase right here. Now you can see as you start getting more blood to go in, eventually the blood flow comes down because now the penis erectile tissues are filling up with blood. Once they're full of blood and the penis starts to stretch and the veins start to occlude, you really can't get much more blood in. So at some point, when you get to the full erection phase, you'll see that the arterial flow actually goes down, but the pressure is rather high. So you should see when you have a full erection, you will see very little blood flow in or out, and you will see a high corporal pressure. Now, you're not going to see pressures on Doppler ultrasound. You see the flow. okay, you'll see the flow go down. And you'll actually see a waveform that gives you a certain amount per second. So it won't be a flat line. This is just measuring where the total pressure will be. But the pressure within the erectile chamber continues to go up. And if you use a pressure monitor, you can figure this one out. This is during that rigid phase where the ischiocavernous muscles contract. And you can see, though, that the penis is rigid here. The blood flow in is almost zero. So when you have a full rigid erection, you should have very little blood flow coming in, very little blood flow coming out. You then start having detumescence or loss of erection. And as you do that, you can see the flow actually will increase a little bit. You get back to your baseline, but the pressure continues to go down until you have what's called fast tumescence, and it's all the way soft again. Now keep that in mind because this is important to the timing when you're doing penile duplex Doppler ultrasound. And this is that same curve I just showed you. And what I'm trying to get across here is what you should expect the changes to be in the penile artery diameters and the flow waveforms that you should expect to see when you're doing these Doppler ultrasounds. So when the penis is flaccid, this is sort of the constricted phase of the arterioles. They're kind of like this. You see kind of very little arterial signal here. As you inject and you start to get a partial erection, which is right around here, you can see the artery inflow goes up and your venous pressure is still there because you haven't achieved complete erection. As you get more tumescent, meaning more full, this waveform actually starts to decrease over time. And when you get the full rigid erection, you should have normalization where the end diastolic velocity goes to zero or below. The rigid erection phase, where the ischiocavernous muscles constrict, as I told you, there should be no blood flow either going in or out, so you shouldn't see an arterial or venous waveform here. And as it becomes detumescent again, it should revert back to the original flaccid state. So if you're going to remember one thing about this talk, this is a very good slide to keep in the back of your mind because it will tell you what to expect, and it also accounts for some of the erroneous readings that some people give. If you don't time the duplex ultrasound just right, you may not see peak waveforms, meaning in a young man, if you give them an injection and they have very good arterial response, within 2 minutes, they may get to a full erection. And you can see that the peak here is less than it is here. So it may look like they have arterial insufficiency, but what they have done is they've gotten to the full rigid phase of erection, and you just missed the latent or tumescent phase. So be careful when you're doing these. A lot of times we have to govern and change some of the protocols of the studies based on the patients and their history. So you have to ask patients, even when you're doing these studies, constantly, how hard do you normally get? Are you as hard as you normally get at home? And things like that. And again, here are sort of your Doppler waveforms. And many people will do injections and then they'll image every 5 minutes or every 2 minutes. But if you're looking here just after injection, you can see you have sort of a Doppler waveform that's low resistance, and then they get, this is more during the tumescent phase. You can see that there's a peak arterial phase and almost no diastolic phase. When you get to the rigid phase, you should have reversal of flow. And when there's high intrapenile pressure, so this would be during the rigid phase of erection, you see almost no flow in or out. So it's a very dampened arterial flow. Now, you can have a young man get here in 5 minutes, and if you interpreted this as arterial insufficiency, you're probably doing it wrong. So if they do have arterial insufficiency, you would see a low velocity here, but you probably will not see veno-occlusion because the amount of blood flow coming in is not enough to fill out the chambers enough to get veno-occlusion. So keep that in the back of your mind because that is one of the pitfalls of doing these. You have to really adapt to the patient and their complaints. So what are the indications for penile duplex Doppler ultrasound? Why would you do that? So on the left are pretty much most of the current indications. So it's indicated for the evaluation of erectile dysfunction, and we'll go over exactly what areas are suggested for that. the evaluation of Peyronie's disease, and I'm going to discuss what Peyronie's disease is in just a bit, evaluation of penile trauma, so patients who come to an emergency room with a penile fracture, urethral rupture, things like that, evaluation of some priapism, evaluation of penile masses, though I must say most of this has gone the way of MRI, and urethral stricture disease. So there's still indications in the area of urethral stricture disease. So people should be thinking about the indications and make sure we're doing these workups when it is appropriate. I know that's an odd slide. This is a slide now telling me that we're going to switch gears and talk just a bit about erectile dysfunction. The reason I do that is that it just reminds me that you really can't look at somebody and tell when they have this problem. Men all across the board with different social levels, different backgrounds, different medical problems will have erectile dysfunction, and it can be very, very problematic to them. This is a very personal issue for most men, and when they have it, they lose self-esteem. Many times that it will impact their work, their home life, their family life. So it sometimes is very important for us to come up with a diagnosis. The definition of erectile dysfunction came back out in early 1999, and it's the consistent or recurrent inability of a man to attain and or maintain an erection sufficient for sexual performance. And the incidence is much higher than you think. So again, the overall incidence is about 26 per 100 per 1,000 man years. But if you actually look, it's about 29% from age 50 to 59, 46% from 60 to 69, and it increases per decade. Now, if you have other risk factors for erectile dysfunction other than age, such as diabetes or hypertension, heart disease, coronary artery disease, peripheral artery disease, this increases the risk. So if you're 50 years old and you have diabetes, your risk is about 50.7%. So 1 out of 2. And many of these patients are being impacted terribly. And by and large, a lot of physicians never make a diagnosis for them. Partners are concerned that either the patient's no longer attracted to them, or they're because they're not able to have sex with them, they are maybe having sex outside the relationship, and that many times is not true because these men have significant vascular abnormalities. So this is an algorithm that came from the Internal Consultations on Sexual Medicine, and it basically breaks down when further cardiovascular or penile duplex Doppler ultrasound is warranted. So if you have findings that necessitate it, meaning any history of coronary or cardiovascular disease, an unstable cardiovascular condition, pelvic perineal trauma, or any penile abnormality such as Peyronie's disease, significant history of prostate cancer, or treatments thereof, these tests are indicated. And this is actually from this book, Sexual Dysfunction Assessment in Men. These are the recommendations for studies to work up men with erectile dysfunction. So if you look at the vascular causes, there's 2 tests that essentially are indicated. Now, the intracavernosal injection and pharmacotesting ICI is included in Doppler ultrasound. So I'm going to include these as one. But the only other test that's really got a B rating, and in our literature, you have to have an overwhelming amount of papers to get an A rating, are dynamic infusion, cavernosometry, and cavernosography. Interestingly, the shortcut for that is the DIC test, D-I-C-C, and color duplex Doppler ultrasound. So if you look, this is, I'm not really talking about the DIC test, but this is a dynamic infusion, cavernosometry, and cavernosometry. It is quite a tour de force for a patient. You have 2 needles hooked to saline pumps, one going in, one measuring pressure. There's also a scan that measures rigidity, and you push down on the penis. Most men are not terribly in favor of this because they get 2 needles in the penis. So because of that, dynamic infusion cavernosometry and cavernosography is kind of, very few people do this, and it basically has been replaced in most hands by the penile duplex Doppler testing due to the less invasiveness of the procedure. Now, the other indication that we're going to talk a little bit about is Peyronie's disease. Peyronie is a guy's name. He was the king to Louis the. I'm sorry, he was the surgeon to King Louis the 15th, and he was the first to write a big paper discussing the rosary beads of scar tissue that cause upward curvature of the penis during erection. Now, he was not a bright man. He thought, as almost everybody at that time who was a barber, that these were due to some sort of sexually transmitted disease, usually syphilis. At the time, the major therapy for the treatment of syphilis was arsenic. And he actually wrote that it worked in about 50%, but because of 50% of the patients never came back. So the history of medicine may always not take us to the place we like to go. Peyronie's disease is an acquired penile abnormality characterized by fibrosis or scarring of the coating, the tunica albuginea, which may be accompanied by pain, deformity, erectile dysfunction, and or distress. We don't really know the exact incidence. It's somewhere around 7 to 20%. It's seen a little bit higher in diabetic patients and patients who have had prostatectomy, and can manifest in several different ways. The most common way is with curvature and scar tissue and a palpable lump. Some people actually just present with erectile dysfunction. Some people present with penile swelling and pain. If you look at these patients, they have lots of issues. So 1 in 10 has relationships that have broken down completely due to the Peyronie's disease. 45% of men say that doctors weren't very helpful. 1 out of 10 tells no one, not even a doctor, about this problem. 25% of men with Peyronie's disease are no longer sexually active. 40% were not offered any treatment at all because many physicians, including urologists, don't really feel that we have very much to do to treat these patients. And 20% of these men feel that they will be laughed at if they talk about it. So you can see it comes with a lot of emotional baggage. There have been recent advances in the treatment of Peyronie's disease, including there is a new injectable agent that's been out for a couple of years. 2015, the American Urologic Association produced a guideline recommendations for the treatment of Peyronie's disease. And if you look in this box, once they get to this stable state, what's recommended is to perform in-office intracavernosal injection with or without penile duplex Doppler ultrasound. And basically what this does allows us to classify the
Excuse me, Dr. Sklar, but we seem to have lost your connection. No sound. I don't know if you can jiggle your microphone. There we go. All right. Thank you.
Can you hear me now?
Yep, you're back. Thank you.
Okay, I'm sorry. Again, they should be prepared when they get there. They should know they're going to get an injection in the penis. Many times it's important, if you don't have materials to cause sexual stimulation, that you advise patients to bring phones, iPads, or some other thing that they can look at sexually stimulating videos and the like. Sexual stimulation, these tests are difficult. And you have to understand that the environment with a physician in a room with a technician and a needle is not inducible to normal erections. So typically we want to do this in a quiet room in the presence of only the operator and assistant if needed. Many places will have an audiovisual setup, as I discussed, but sometimes patients just bring their phones or iPads. You definitely need intracavernosal injection supplies, a syringe, a needle, whatever agent you use, and we'll talk about those briefly. And you need warm gel. I will tell you that nothing really takes away the erection better than some nice ice cold gel. You need a well-trained sonographer, and equipment has to have standard colored Doppler ultrasound with real-time image scanning high resolution solid state linear array transducer between 7.5 and 12 megahertz, particularly for small parts. And the store expect to have just a little tray with the injections, the warmed ultrasound, the machine itself, and any kind of table will do. Preferably the same ultrasound machine should be used to perform all of these scans, meaning you don't want to start with one machine and then go to another. Again, you want to get an informed consent because there are potential side effects, and the consent should include things like prolonged erection or priapism, scarring, penile discomfort. Instruct the patient to get in the supine position and try to relax as much as possible. And again, usually before I do the injection, we do a baseline ultrasound. You take the probe with gel, and you'll do a baseline scan of the right and left penile shaft in both longitudinal and transverse views, both dorsally and ventrally, to observe the baseline anatomy and the ecotexture of the corpora cavernosa. So you're looking for, particularly in Peyronie's disease, you will be looking for calcified plaques, which should be easily identifiable. I'll show you those in a little bit. So next, we're going to obtain the transverse and longitudinal images. And again, you want to get the artery sort of in the mid segment of the penis. You want to take measurements of the intraluminal diameters on the left and right. And then we would start doing the injection. And the injection is done with a very small needle, 27 to 30 gauge needle. And we use one of the following agents, either papaverine, phentolamine, prostaglandin, or a mixture called trimix. And we inject actually into the corpora cavernosum. And I'm going to show you a brief video about how to do that. But typically, you want to do that if you're looking at the penis as a clock from the 1 o'clock to 3 o'clock positions on the patient's left side of the penis, or the 11 to 9 o'clock position on the right side of the penis. And you want to go right into the erectile chamber. Again, most of these will require some sexual stimulation. So before I start this video, you're looking at a schematic of the injection site. And this is sort of the area that we're talking about. So you're looking from about 1 o'clock to 3 o'clock, or 11 o'clock to 9 o'clock. And here is a sort of dummy model of the penis. And those are the areas, and you want to stick the needle in, and you want to stick it in quickly, pretty much all the way in, and inject. Now, sometimes it's rare if a doctor is doing this and doesn't get a response. Occasionally, you can inject into the septum. Some people will pull back on the plunger just to make sure they get a little withdrawal of blood to make sure they're in the corporal chambers. And then the imaging will then ensue. Now, everybody has different protocols. I'm going to go over one of the protocols, but you will start imaging both dorsally and ventrally to identify the vessels, to look for, again, plaques, and then do all of our measurements that we'll talk about. So here's an ultrasound. We're going to look at like painting and fanning techniques. Originally, you will start usually on the dorsum of the penis, because that's where the vast majority of Peyronie's plaques would be, on the dorsum of the penis. Some of them are ventrally as well. So you're looking at the sort of painting the penis this way. And as you go farther laterally, you're going to do some longitudinal, and you'll do some fanning techniques. And then you're going to look for the arteries on both sides. So sometimes patients will help you. You know, if you're going on the ventral side, you may ask them to if you're looking for urethral lesion, you want to go from the bottom. If you're looking for urethral stricture disease, many times people will do injections of gel into the urethra to fill the lumen of the urethra to see if you can see strictures. So there's a lot of added things you can do depending on what type of test you're looking for. But for classic penile duplex Doppler ultrasound, you're mainly going to be looking, this is now looking for arteries, and you want your angle, you know, somewhere around 60 degrees. if somebody has a large scar on the dorsum, you can go ventrally, and this is showing views as you go and start doing fanning laterally. You can see the corporal artery was in the middle. Now you're getting to the other side, and there's the other corporal artery up at the top. You can do corporal artery diameters through this, and depending on the phase, then you want to start doing your Doppler ultrasound. So here's your angle, again, somewhere around 60 degrees is what you're looking for many times. And you'll see there's very little flow to begin with, and as time goes on, your Doppler flow signal will increase over time. You're now starting to see an increase in Doppler flow. This is sort of a baseline. Then you're going to see inflow come in during the sort of latent phase of erection. And when that happens, you'll start seeing some of the end diastolic vessels. So you see the end diastolic flow here. This is the early phase of erection. You have inflow. You still have end diastolic flow. As you go on, you're going to lose that diastolic flow. Or you should lose that diastolic flow. If it persists, then you have an abnormality. So again, we talked about using the angle preferably less than 60 degrees to determine systolic and end diastolic velocities, and these are in centimeters per second. The Doppler angle should not be changed during the study. You need to maintain consistency because that will screw up your readings. You want to repeat this essentially on both sides. You have to remember, because it takes a little while to do these ultrasounds, particularly in young men, you can miss their peak systolic velocity and end up imaging one side during the rapid phase of erection and one during the full phase, and it will look like they have a decreased arterial inflow on the second side. You have to just be cognizant of that. And when you
We've lost your audio again, Dr. Sklar.
I'm not sure where that. Can you hear me now?
Yes, now we can hear you. Thank you.
It's still in there. I'm not sure why you keep losing me.
I don't know.
Anyway, the key is to evaluate the systolic and end diastolic.
All right, we've lost you again.
Hear me now?
Yeah.
It must be my headphones dying. All right, can you hear me clearly?
Yes.
Okay, I'm just going to talk like this.
Perfect. Thank you.
For the peak response, you should obtain a transverse and longitudinal images of the intraluminal diameters on both the left and right side as well. And then there should be a calculated resistance index. Okay. Now, one of the things that people aren't used to doing, particularly ultrasonographers, is measuring and assessing Peyronie's disease. So, and this is very important to document when you're evaluating a patient during a penile Doppler ultrasound, because many times a patient's description of their penile curvature will not correlate with what you see in the Doppler ultrasound. Many times the injectable agent that we give the patient will give them an erection that is significantly firmer than what they experience at home. So the degree of curvature can be significantly greater during the test than it is at home. So they have these devices called the Peyronie's disease assessment device, or the PDAD device, that helps learn how to measure. You can give patients these and they can do this at home as well. And essentially, you just line this up with the base of the shaft and then turn the top portion to be parallel to the head of the penis. You want to put this rotating area at the point of maximal curvature, then bend that down, and you'll see in this particular case, there's about a 40-degree curvature. I know it's not so easy to read, but that will give you the number and degree of curvature, and you can also measure that right and left as well. Back to the protocol. So again, it's very important to go back and forth with the patient, asking the patient about, do they get firmer than this at home, and compare that and document whether they're getting as hard at the study as they do get at home. Many times you have to redose the patient. So if you inject and you don't get a peak systolic velocity that's normal and you still have end diastolic velocity, you may want to re-inject. Again, this is one of the areas of big pitfalls. if they're not maximally relaxed, and when I say relaxed, I mean if the smooth muscle is not relaxed, the blood flow will not reach its peak and can be confusing, and you might think that they have both arterial insufficiency and veno-occlusive dysfunction, and what they really just have is they have performance anxiety because you're in a room with a guy with a needle and somebody measuring their penis with an ultrasound. So if you do reach that, it's always good to give a second injection to make sure that they have a complete erection. Now, after the procedure, it's my personal preference to keep the patient around at least about a half an hour, 15 minutes to a half an hour. I usually reverse the erection using phenylephrine, a dilute solution of 1 to 10 of phenylephrine, and give almost 1 cc every 5 to 10 minutes till you get complete detumescence, because you don't want these patients to go home and then 4 hours later need to go to an emergency room. There are side effects as well as from priapism. If you do have an erection that lasts 4 hours, the odds of having normal erections going forward is significantly less. And then you need some sort of penile Doppler reporting form. And this is one that's out there. You can find this online if you want. The citation is here at the bottom. But you can also come up with any one you want. But the key is having measurements of both peak systolic velocities, left and right, and time. Okay, and same with end diastolic velocity and resistive index. And what you want to do, many people measure the internal diameters and penile length and circumference. That's sort of optional, but the degree of curvature and the direction of curvature are extremely important, particularly for the Peyronie's disease patients. Now, I'm going to go over some of the parameters. Again, you should be getting at least these parameters anytime you're doing penile duplex Doppler ultrasound. This is sort of a normal Doppler during the full erection phase on the right. And the ones that you want to collect are the peak systolic velocity, which would be up here. Okay, that's the top. And they're measuring that one at 52 centimeters per second. I'm sorry, 84.52 centimeters per second. We'll go over what normal is next. Some people do what's called an acceleration time or systolic rise time. That's the time from their baseline to full systolic peak velocity. End diastolic velocity, which would be right here. This is actually reversal of end diastolic velocity. Resistive index is just systolic velocity minus end diastolic velocity over systolic velocity. Should be pretty close to 1 in a normal penis. The degree of cavernosal artery dilatation, that's the measurement of it, but it's thin and inconsistent because it may, again, predict you have to have adequate rigidity. You need additional injections to get the best measurement there. Most important thing is what's normal. Every guy has that question, is my penis normal? And the resting cavernosal artery, these are diameters, are very small, 0.3 to 0.5 millimeters, much smaller than coronary arteries. Post-injection, they like double in size to 0.6 and 1.0 centimeters. I'm sorry, millimeters. Peak systolic velocity should be consistently greater than 35 centimeters per second. That means there's completely normal cavernosal artery inflow. Now, if it's less than 25 centimeters per second throughout the entire study, that usually means that there is some arterial insufficiency. Again, the only caveat to that is in a very young man, if you miss the full phase, miss the of erections, and you hit the rigid phase, you may see a peak systolic velocity less than 25 centimeters, but the patient should have a rigid erection and an end diastolic velocity of 0 or negative. And when you see that, if it's less than 25 centimeters per second, you should suspect that you just missed it by imaging too late. A resistive index of greater than 0.9 has been associated with normal penile vascular function, both arterial and venous, and a resistive index less than 0.75 is consistent with veno-occlusive dysfunction. End diastolic velocity should be 0 or actually reverse, but anything less than about 5 centimeters per second is considered normal. I usually will document it either way and say that they may have some mild corporovenous occlusive dysfunction if it's around 5. And now I'm going to go over some cases here real quick. And I'm going to start doing some of the polls I discussed. So this is the case 1, and this is after injection. This is a good 10 minutes after injection. And in this particular patient, he actually had re-injection. And you can see that his peak systolic velocity is 21.5, and his end diastolic velocity is 9.1. Okay? So with that information, I'm going to give you this poll. The Doppler image in case 1 is at 20 minutes after redosing. What is the diagnosis? And your choices are arterial insufficiency, veno-occlusive dysfunction, combined arterial and veno-occlusive dysfunction, and high flow priapism. So go ahead, I'm opening the poll. Go ahead and respond. I see you guys are responding. About 10% of you, and I'll let it get up to about 50%. So keep voting, keep voting. I should have some music in here. Does anybody have any good penis music? I don't have any. Okay, we're up to about 40%. Okay, I'm going to go ahead and close this. And here are the results. Most of you thought this was arterial insufficiency. 18% thought it was veno-occlusive. 24% thought it was combined, and 9 thought it was high flow priapism. So what is this? Let's see. So this is arterial insufficiency, because at some point you do get an end diastolic that's almost 0. The peak systolic velocity is less than 25 after repeated dosing. Many times with arterial insufficiency, you will not have complete veno-occlusion if you do not have significant arterial inflow. Again, I told you, you can miss the peak inflow if the patient's very young. You may have imaged at the rigid erection phase. However, what you would expect is a low velocity arterial signal with reversal of end diastolic flow. That is not what you have here. So you do have arterial insufficiency in this slide. So in this case, we need more flow, Scotty. All right, so this is case number 2. So the Doppler image in case 2 is at 20 minutes, and again after redosing. What is the diagnosis? Now, this peak systolic velocity here is 22, but the end diastolic velocity after redosing is 11.13. Do 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 do. Okay, we got 50%. We're going to go ahead and close the poll. And so most of you thought this was combined arterial and veno-occlusive dysfunction. I'm going to hide the results. And this is mixed arterial and venous insufficiency. Very good. So you have a peak systolic velocity that's continuously less than 25 centimeters per second. The end diastolic velocity is greater than 5 to 10 centimeters per second, and this resistive index is 0.5, which means it ain't normal, and usually there's a venous problem in there. Very good. Okay. So everything in this case is broken. This is the next one. Again, this is at 20 minutes after redosing. What is the diagnosis here? So to go over the numbers, the peak systolic velocity here is 55.57. The end diastolic velocity is 26.84. And we have 15% in. Do, 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 do. So 67% thought this was veno-occlusive dysfunction, and you are right. So this patient has a peak systolic velocity greater than 30 centimeters per second, so he has normal arterial inflow. The end diastolic velocity is greater than 10 centimeters per second. The resistive index is less than 0.75, so he has venous insufficiency. Now, most of these patients, when they have a complaint, they talk about incomplete erections and difficulty maintaining the erection. So most people call this corpora venous occlusive dysfunction or venous leak type erectile dysfunction. So it seems as though we sprung a leak there, folks. Okay, let's see. I'm just going to skip the next poll. This right here, you see peak systolic velocity here that's quite high. And you see reversal of end diastolic velocity there. Now, the problem with this case, let me show you, there's two phases of it. I don't think the first phase showed. Here's the first phase. So when you're looking at this, at the beginning, you see a velocity that's somewhere around 40 in, but your end diastolic velocity is somewhere around 9 or 10. Now, if you read this as is, you would call this corporo-occlusive venous disease. This was at about 5 minutes, so we re-injected. And when you re-inject, this is what you see. So you get a peak systolic velocity of about 69 centimeters per second with complete reversal of end diastolic velocity. So this is what's called pseudo-veno-occlusive dysfunction. There's actually no abnormality. It's completely normal. The pseudo comes from the interpretation that there was complete smooth muscle relaxation and that you're looking over here at a point that is the best erection the patient's going to get. Unfortunately, you have to be very careful with these. If they're not all the way firm, they say they're getting firmer at home, I encourage you to re-inject because many times you're going to call venous occlusive dysfunction. You re-inject and that completely resolves. So that's pseudo-veno-occlusive dysfunction. Now, as I told you for Peyronie's disease, the guidelines suggest that you should be doing penile duplex Doppler ultrasound. These are echogenic or calcified plaques with a post-acoustic shadowing. These are Peyronie's plaques that you can see. You can see them in the longitudinal. You can see them in the transverse planes. They can be dorsal. They can be ventral. You should look for these, and when you see them, you should measure them. Again, when you do these, you should measure the curvature, measure the flow parameters. And again, this is now directing treatment, okay? So you may not know exactly what treatment the patients end up with, but the Doppler ultrasound puts the patients in basically one of four buckets, ranging from injection therapy to excision and grafting to a penile prosthesis. So this is a patient who had a complaint of penile pain with intercourse, and it had a buckling event. This is the most common way penile fractures present. It's kind of interesting the way patients say it. Many times they'll come in and they'll say they were doing something completely unrelated, like bowling, and they hit their penis with a bowling ball. Well, if you look over here, you see this is the tunica albuginea, the white layer, and then there's an area outside the white that has blood in it, which usually means that there is, some blood or herniation of tissue through the coating of the erectile chamber. So that's a penile fracture. And that's something that you should be able to identify on Doppler ultrasound. Many times the stories don't line up. Now, the problem is, and I had a patient who presented with that bowling story. Interestingly, he came to an emergency room at 2 o'clock in the morning. Most bowling alleys aren't open at 2 o'clock in the morning. So right then and there, you can disregard the story. And I questioned the patient about the bowling injury. And I said, so let me get this right. You were in a bowling alley. You were laying on your back and your partner was on top of you. And he looked up at me and said, how did you know that? So there's a couple things about penile fractures. Penile fractures can only occur to an erect penis, okay? So any patient telling you that they were minding their own business and they got hit with a ball in their penis, that's not how this occurs. It has to be erect, and typically a partner is in a position on top, either facing forward or backwards, because that position has the highest pressure on the penis. And it exerts a pressure that's not parallel to the shaft of the penis, so it makes it much more likely to have a buckling injury. So these are important. Most of these, when you see something like this requires surgical correction and a trip to the operating room. If we're going to switch to priapism. So priapism is a sustained painful erection. Often the erections will last over 4 hours or so, but after about 3 hours, you start having pain. When you see this, there's two different types. There's painful priapism, or what's called ischemic priapism, and there's non-ischemic priapism. The ischemic type of priapism usually requires treatment. The non-ischemic can be treated conservatively and will usually get better on its own. The hallmark of non-ischemic priapism is the penis is firm but is not causing pain. High flow priapism or ischemic priapism causes pain, and typically you'll see a high systolic velocity and a high end diastolic velocity, and that lets you know it's high flow priapism. Usually with the diagnosis, it would be you're not dealing with a ischemic type priapism. You have inflow and outflow. And here's a representation of a high inflow and no occlusion. So you have inflow and outflow, and that's usually signifying a fistula between the cavernosal artery and the sinusoids of the penis. Many times these will close off over time because they're not full rigid, so they can be treated conservatively for several months. If you're looking at a patient with low flow priapism or ischemic priapism, they have almost no flow in, no flow out. It's like imaging a patient during the rigid phase that I showed you earlier. Now, penile ultrasound, as I said, can also be used for urethral stricture disease, and some people inject gel and even bubble type gel and gel type contrast per urethra, but you can see these areas right here have an irregularity of the urethra, and this is urethral stricture disease. It is in the current AUA guideline for evaluation of urethral stricture disease. You can either use cystoscopy, retrograde urethropy, voiding cystourethropy, or ultrasound urethropy to make the diagnosis of urethral stricture. It can also be used, as I discussed, for penile masses, and in this patient you can see there's a central mass in the corpora itself. It's heterogeneous, but nowadays most of these have been replaced by performing MRI. It gives you much more detail, whether it's invading the tunica, albuginea, or the corpora spongiosum as well. So by and large, these are not really recommended for evaluating penises. Now, I will tell you that occasionally a patient will come to the emergency room and a physician, they usually present with chest pain and priapism. This is a very difficult situation. When they have chest pain and priapism, the ultrasonographer's role is to look to make sure they don't have one of these. So I don't know if you know what this is. This is an ultrasound of the groin, actually the lower quadrant, and this is the parallel walls of a reservoir for a penile prosthesis. So this is not uncommon for a man to present with chest pain, and what the emergency room thinks is priapism. And typically what happens is the patient inflated his penile prosthesis, he had sex, he had chest pain during intercourse, did not get a chance to take down his penile prosthesis, and the ER doc sees it inflated and thinks he has priapism and wants to stick a needle in it. So you can save a significantly expensive problem by identifying those things. So I'm going to go ahead and cut this talk off and make a graceful exit. I want to thank you for your attention, and at this point I'd be happy to answer any and all questions that you may have. Darcy, you still there?
I am. Are you able to see any of the questions?
Yeah, I'm converting right now.
Okay.
So,
yeah, I'm going through them. And
is there any relationship between the patient's psychological status and blood flow despite we are injecting the materials? Sure. So that's what I was saying. In patients where you inject and you don't see complete smooth muscle relaxation, they get a peak systolic velocity less than 25, and they have end diastolic velocity, you may want to redose. And I've actually redosed up as many times as 4 times in patients. And after a significant period of time, if you don't get it above that, it's not usually psychological. The psychological ones you can usually outdose. So redosing will get rid of some of that psychological stuff. The angle correction should be less than 60 degrees. Where do you usually take the Doppler signal? Well, you take the Doppler signal where it's the easiest to see. So in different patients, it may be mid-shaft dorsally, and other patients, it may be mid-shaft ventrally. But you want to do it, and there are some patients where they will have what's called focal veno-occlusive dysfunction. So some patients with Peyronie's disease, you'll see them, they have rigidity proximally, and they have flaccidity distally. So you may need to measure proximally and distally to get both arterial and venous flow, because distally, if you do it, you can identify what's called a focal veno-occlusive dysfunction, which is not uncommon with Peyronie's disease. This examination will rule out only, it doesn't rule out other causes, like the test doesn't identify neurologic causes of erectile dysfunction. This is only looking at vascular, and it will to some degree identify corporal problems, meaning smooth muscle problems and tunico-albugineo problems. So it does not usually identify anything that's neurologic. Is there any relationship between penile dysfunction and varicoceles? So, no, so varicoceles are dilation of the vessels to the testicles. It's not so, there's no direct one-to-one correlation of erectile dysfunction with varicoceles. There is a relationship between varicoceles and fertility. Some portion of men who have varicoceles have infertility, but not known to cause a problem with erectile function. So one question here is, what is the management of veno-occlusive disease? So it depends on the severity of veno-occlusive disease. People used to do venous ligation, which does not work. So that's not the treatment of choice. If you have very mild veno-occlusive disease, sometimes things that increase the artery flow will cause resolution of veno-occlusive dysfunctions. I told you, if you redose, some people that you think have veno-occlusive disease will then have normalization. So either you can try oral erectogenic agents if they haven't tried them, like Viagra, Levitra, Cialis. You can use injection therapy where they're injecting the same agents that you use during the Doppler ultrasound. Or you can use a constricting band around the penis or a penile ring. Sometimes those work. If none of those work, the end therapy would usually be using a penile prosthesis. Is there hyperemic flow like you see with orchitis? So not typically. You can get what's called balanitis. That's usually in the glands. So we don't usually really register flow in the glands because it's very hard to scan the glands unless you're looking for tumors. So we don't usually the hyperemia you would see would be to the skin. So occasionally you can see a lot of blood flow to the skin in patients with a lot of dilated vessels, and occasionally with patients with what's called Mondor syndrome, which is a dorsal venous thrombophlebitis. But you should be able to see luminal occlusion in that dorsal vein, but you're not really going to see hyperemic flow. How do you confirm the venous leak diagnosis? Really, the only way to confirm the venous leak diagnosis is to re-inject and make sure that they still have persistent diastolic velocity greater than 5.
Okay, I think we're going to have to end
Can
there.
a vascular lesion happen on one side? I'm sorry?
I think we're actually probably going to have
sorry,
to.
I couldn't hear you.
Can you hear me now?
Yeah, do you want me to go over this last one? This is the last question.
Okay, last question.
Can a vascular lesion happen on one side? Yes, it can. Most common reason that would happen is a pelvic trauma, and it would usually happen at the level of the internal hypogastric or the internal iliac vessel.
Wonderful.
That's it.
Well, thank you very much, Dr. Sklar. And on behalf of the AIUM, our thanks to all of you who have participated in today's webinar. So please remember to complete the post-test and the activity evaluation. And we hope you enjoyed the presentation and will join us again for future webinars. Goodbye, everyone.